we'll continue with the second part of the retina video. Primary retinal telangiectasia. Retinal telangiectasia refers to idiopathic congenital or acquired retinal vascular malformation characterized by irregular dilation of capillary bed and segmental dilation of neighboring venules and arteries. Primary retinal telangiectasia include idiopathic juxtafoveolar retinal telangiectasia, Coats disease, Leber's miliary aneurysm. Idiopathic is the cause is unknown. It is presenting with mild decrease in visual acuity due to exudation from juxtafoveal telangiectic retinal capillaries. This condition has been divided into three groups, 1, 2, 3, depending on the characteristics of lesion. Coats disease, also known as exudative retinopathy of Coats, is a severe form of retinal telangiectasia. Characteristic features are it typically affects one eye of boys in first decade. In early stage, it is characterized by large areas of intra and subretinal yellowish exudate and hemorrhage associated with overlying dilated and tortuous retinal blood vessels and a number of small aneurysms near the posterior pole around the disc. It may be present with visual loss, strabismus, leukocoria, and thus need to be differentiated from retinoblastoma. Condition usually progresses to produce exudative retinal detachment and retrolental mass. In late stage, complicated cataract, uveitis, and secondary glaucoma occur, which eventually end in phthisis bulbi. FFA highlights abnormal vessels, leakage, and areas of capillary dropout. Treatment is as below. Photocoagulation or cryotherapy may check progression of the disease if applied in the early stage. However, once retina is detachment, the treatment becomes increasingly difficult, and success rate declines to 33%. Leber's miliary aneurysm. Leber's miliary is essentially a localized, less severe form of Coats disease, presenting with adult decreased vision, characterized by local area fusiform saccular aneurysm, dilation of venules and arterioles, associated local exudation. Treatment consists of direct photocoagulation of abnormal cells. Ocular ischemic syndrome. Etiology. Ocular ischemic syndrome refers to a rare condition resulting from chronic ocular hypoperfusion secondary to 90% of stenosis of carotid artery. Carotid stenosis refers to atherosclerotic occlusive carotid artery disease often associated with ulceration at bifurcation of common carotid artery. Risk factors for carotid stenosis may include male gender, old age, smoking, hypertension, diabetes mellitus, hyperlipidemia, etc. Manifestation of carotid occlusive disease include amaurosis fugax, retinal artery occlusion, transient cerebral ischemic attack, stroke, etc. Clinical feature: ocular ischemic syndrome is usually unilateral, affecting elder males more commonly than females. Symptoms include loss of vision, which usually progresses gradually over several weeks or months. Transient blackouts, amaurosis fugax maximi may be noted by some patients. Pain, ocular or periorbital may be complained by some patients. Delayed dark adaptation may be noted by few patients. Signs: cornea may show edema and stria. Anterior chamber may reveal faint aqueous flare with few cells. Pupil may be mid-dilated and poorly reacting. Iris shows rubeosis iridis and atrophic patches. Cataract may occur as a complication in advanced cases. Neovascular glaucoma is frequent sequelae to anterior segment neovascularization. Fundus examination may reveal venous dilation, retinal artery narrowing. Veins are dilated. Retinal artery narrowing. Retina shows mid-peripheral dot, blood hemorrhages, microaneurysm, cotton wool spots, etc. Retinal neovascularization is noted in 37% cases, which may be in the form of NVD, occasionally NVE, macular edema, DD, differential diagnosis. Ocular ischemic syndrome needs to be differentiated from non-ischemic CRVO, diabetic retinopathy, hypertensive retinopathy, and aortic arch disease caused by Takayasu arteritis, aortoarteritis, atherosclerosis, syphilis, etc. Treatment: investigation, Doppler ultrasound, magnetic image angiography. Treatment of ocular ischemic syndrome include treatment of neovascular glaucoma, treatment of proliferative retinopathy by pan-retinal photocoagulation, treatment of pseudoitis with topical steroid eye drops. Treatment of carotid stenosis is medical and surgical carotid endarterectomy. Differential diagnosis of ocular ischemic syndrome. Similarities and differences: non-ischemic CRVO, unilateral retinal hemorrhages, venous dilation, cotton wool spots. Veins are more tortuous, hemorrhages are more numerous. Normal retinal arterial perfusion, disc edema, sometimes opticociliary shunt vessel can be seen on the disc. Diabetic retinopathy, microaneurysm, dot and blood hemorrhage. venous dilation, NVD, NVE, cotton wool spots. Mostly cotton wool spots are common. Arterial narrowing, hypertensive retinopathy, aortic heart disease, arterial narrowing, retinal hemorrhage, focal constriction. Here usually bilateral, no marked venous congestion, usually bilateral, absent on neck pulses, etc. Dystrophies and degeneration of retinal dystrophies. Hereditary retinal dystrophy primarily affect the outer retina, RPE, and photoreceptors. Common retinal dystrophies are generalized photoreceptor dystrophy. They involve entire retina, peripheral retina more than macula. Typical retinitis pigmentosa and its variant, progressive cone dystrophy, label congenital amaurosis, congenital stationary night blindness, congenital monochromatism. Macular dystrophy involve the macular area, juvenile best macular dystrophy, Stargardt's disease, vitelliform disease, retinitis pigmentosa. It is primary pigmental retinal dystrophy is a hereditary disorder. It affects more commonly rods than cones. Inheritance. Retinal pigmentosa may occur as sporadic disease, isolated without family history due to mutation of multiple genes, including rhodopsin gene. Inherited disorder. Autosomal recessive, most common. Intermediate severity. Autosomal dominant, X common. X-linked 10%. Prevalence 1% per 1% per 5,000. Age, childhood. Appears in childhood, progress slowly, often resulting blindness in advanced middle age. Race, sex, more common in males than females. Laterality, it's almost invariably bilateral and both eyes are equally affected. Pathogenesis. Group of majority of retinitis pigmentosa condition are characterized by death of rod photoreceptors by molecular mechanism by which genetic mutation eventually causes rod cell death, and they are unclear, and although ample evidence indicates that apoptosis is involved in final path of cell death, that cone photoreceptors ultimately die from a disease that begins with rod cell disease remains as a puzzle. Clinical picture. Typical retinitis pigmentosa rod cone dystrophy, in which rods are degenerate early and cones are involved late, is characterized by following features. Night blindness. It is characterized by and earlier feature and may present with several years before visible changes in retina appear. It occurs due to degeneration of rods. Dark adaptation. Light threshold of peripheral retina is increased, though the process of dark adaptation itself is not affected until very late. Tubular vision. Loss of peripheral vision with preservation of central vision occurs in advanced cases. Central vision almost lost ultimately after many years. Fundus changes. Retinal pigmentary changes. Fundus picture of retinitis pigmentosa with consecutive optic atrophy. Field changes in retinitis pigmentosa. First fundus changes. Retinal pigmentary changes. These are typically perivascular around the veins and jet black spots resembling bone corpuscle in shape. Initially, these changes are found in equatorial region only and later spread both anterior and posterior. Retinal arteries are attenuated, narrowed, may become thread-like in late stages. Thread-like. Thinning and atrophy of retinal pigment epithelium, RPE, is thinning and atrophy is seen in mid and far peripheral retina with relative sparing of RPE at macula. Optic disc become pale and waxy in later stages. Ultimately, consecutive optic atrophy occurs. Other associated changes which may be seen are colloid bodies, choroidal sclerosis, cystoid macular edema, atrophic or cellophane maculopathy. Visual field changes. Annular or ring-shaped scotoma. Annular or ring-shaped scotoma. Is a typical feature which corresponds to degenerated equatorial zone of retina. As the disease progresses, scotoma increase anteriorly and posteriorly, and ultimately only central vision is left. Tubular vision is left. Eventually, this is lost after many years. Electrophysiological changes. Typical electrophysiology appear early in disease before subjective symptoms appear. Electroretinogram is initially subnormal. Scotopic affected before photopic. B wave affected before A wave, and eventually extinguished. Electrooculogram is abnormal with absence of light peak. Association of retinitis pigmentosa, ocular associations, systemic associations. Ocular, myopia, primary open angle, microphthalmos, conical cornea, keratoconus, Posterior subcapsular cataract. Systemic. Most cases are isolated, but 25% are associated with some specific diseases. Lawrence Moon Beadle syndrome, Cockayne's syndrome, progressive infantile deafness, dwarfism, mental retardation, nystagmus, ataxia, Refsum syndrome. It is characterized by retinitis pigmentosa, peripheral neuropathy, cerebral ataxia, Usher syndrome. It includes retinitis pigmentosa, labyrinthine deafness, Hallgren's syndrome. It comprises retinitis pigmentosa, vestibulocerebellar ataxia, congenital deafness, mental deficiency, etc. Other associated syndromes include Bussen's-Korenzi syndrome, Kearns-Sayre syndrome, Friedreich ataxia, Bardet-Biedl syndrome, NARP, neuronal ceroid lipofuscinosis, olivopontocerebellar degeneration. Atypical forms of retinitis pigmentosa, cone rod dystrophy. In this condition, cones are degenerate earlier than rods. Central vision is reduced first. Color vision is defective. Defective vision in bright light. It's directly opposite to the rod cone dystrophy, that is retinitis pigmentosa. Retinitis pigmentosa is shiny pigmento. It is characterized by all the clinical features of typical retinitis pigmentosa, except that there are no visible pigmentary changes in fundus. No pigmentary changes, black spots, narrowing of arteries, etc. are not seen. Sectorial retinitis pigmentosa is characterized by involvement of only one sector of retina. Pericentric. In this condition, clinical features are similar. That pigmentary changes are confined to an area immediately around the macula. Behind macula, the pigmentary changes are seen. Pigmentary. Retinitis punctata albescens is characterized by presence of innumerable discrete white dots. Albicans means white over the fundus without pigmentary changes. No other pigmentary changes, but white spots are seen. Retinitis punctata albescens. Other features are narrowing of arteries, night blindness, constriction of visual field, etc. Treatment. Measures to stop progression, which have been tried from time to time without any breakthrough, include vasodilator, placental extract, transplantation of rectus muscle into suprachoroidal space, light exclusion therapy. Recently, vitamin A has been recommended to check its progression, correct any refractive error, prescribe glasses, systemic acetazolamide for cystoid macular edema, acetazolamide. Low vision aids in the form of magnifying glasses, night vision device may be of some help. Rehabilitation of patient should be earned out as per his socioeconomic background. Prophylaxis, genetic counseling for non-consanguine marriages should be given. Retinal degeneration or acquired disorders of retina characterized by degenerative changes. They can be classified: peripheral retinal changes, vitreoretinal macular degenerations, age-related and myopic macular degeneration. Peripheral retinal lattice degeneration. It is the most important degeneration associated with retinal detachment. 6 to 10% incidence in general population, 15 to 20% in myopic patient. Characteristics: white arborizing lines arranged in lattice pattern along with areas of retinal thinning and abnormal pigmentation. White arborizing line. Small round retinal holes are frequently present in it. A typical lesion is spindle shaped, located between ora serrata and equator, with its long axis being circumferentially oriented. Involves more frequently the temporal than nasal and is superior than inferior halves of fundus. Snail tract degeneration. It is variant of lattice degeneration in which white lines are replaced by snowflake areas. Snail tract degeneration. Lattice degeneration. Give the retina a white frost-like appearance. Acquired retinoschisis. The term retinoschisis refers to splitting of sensory retina into two layers at level of inner nuclear and outer plexima layer. It occurs in two forms: congenital and acquired. Congenital is also called as senile retinoschisis. May rarely act as predisposing factor for primary retinal detachment. It is characterized by thin, transparent, immobile, shallow elevation of inner layers. Elevation of inner retinal layers. Acquired retinoschisis. Then, which typically produce absolute field defects The fact which helps in differentiating it from shallow retinal detachment is produced the related scotoma. The condition is frequently bilateral and usually involves the lower temporal quadrants and anterior to equator. White with pressure, white without pressure. White with pressure are characterized by greyish translucent appearance of retina seen on clear indentation. White with pressure. White without pressure are located in peripheral retina, may be associated with lattice degeneration. Focal pigment chumps. These are small localized areas of irregular pigmentation, usually seen in equatorial region. They may be associated with posterior vitreous detachment and retinal tear. Diffuse chorioretinal degeneration. Diffuse chorioretinal degeneration. Diffuse area retinal thinning, repigmentation of underlying choroid. It is commonly involves equatorial region of highly myopic eyes. Peripheral cystoid degeneration. Peripheral cystoid degeneration seen in eyes of old people. Vitreoretinal degeneration. Wagner, Stickler, Favre, Goldman. Familial exudative vitreoretinopathy. Erosive vitreoretinopathy. Dominant neovascular inflammatory vitreoretinopathy. Dominant vitreoretinochoroidopathy. Wagner's as an autosomal dominant in vitreous is liquefied with condensed membrane. Retina shows narrow see-through vessels. Choroid may be atrophy. Cataract may be developed at late complications. Stickler, also known as hereditary arthro-ophthalmology, is an autosomal dominant connective tissue disorder characterized by following features. Ocular features are vitreous liquefied, shows syneresis giving appearance of optically empty vitreous cavity. Progressive myopia is very common. Radial lattice-like degeneration associated with pigmentary changes and vascular sheathing. Bilateral retinal detachment may occur in 30% cases. Ectopia lentis is occasionally associated. Presenile cataract occurs in 50% cases. Orofacial abnormality include flattened nasal bridge, maxillary hyperplasia, cleft palate, high arch palate, etc. Arthropathy is characterized by stiff, painful, prominent, hyperextensible joints. Other features include deafness, mitral valve collapse, Favre-Goldman syndrome. It is an autosomal recessive condition presenting in nyctalopia. Presenting with childhood with nyctalopia, vitreous shows syneresis, but cavity is not optically empty. Retinocysis, both central and peripheral, is present, affecting macula, although macular findings are more subtle. Pigmentary changes similar to retinitis pigmentosa are marked. ERG is abnormal in Favre-Goldman syndrome. Macular disorders. Macula, being concerned with vision, has attracted the attention of many retinal specialists. Consequently, many disorders have been identified. Simple etiology classification, broad overview of macular lesions is as follows. Congenital anomalies include aplasia, coloboma, hereditary dystrophies, best diseases, Stargardt's, bullseye, butterfly. Acquired maculopathy, traumatic lesion, these include traumatic macular edema, traumatic macular degeneration, macular hemorrhage, macular hole, inflammation, central chorioretinitis, solar retinopathy, photoretinitis, degeneration, ARMD, metabolic disorders, diabetic maculopathy, spondylolisthesis, toxic maculopathies, chloroquine, phenothiazide induced maculopathy, miscellaneous acute maculopathy. A few common conditions are central serous retinopathy, cystoid macular edema, macular hole, macular epiretinal membrane, vitreomacular attraction syndrome, idiopathic choroidal neovascularization, hereditary macular dystrophy, best Stargardt's, best autosomal dominant Stargardt's. Clinical presentation with decreased vision in first or second decade of life. Fundus examination shows beaten bronze, snail-like reflex in macular area. Best vitelliform stage, pre-vitelliform stage, pseudo-hyperplasia, vitally eruptive stage of scarring. Solar retinopathy, also known as photoretinitis, eclipse retinopathy, refers to retinal injury induced by direct or indirect sun viewing, sun gazing, solar observation, telescopic solar viewing, sun bathing, sun watching in psychiatric disorders. Cause of photic retinopathy, welding or exposure, lightning, retinal phototoxicity from ophthalmic instruments like microscope. Pathology, pathogenesis, solar radiation damage retina through photochemical effects induced by UV and visible blue light. Thermal effects may enhance the photochemical effects. Long visible length and infrared rays from sun are absorbed by pigment epithelium, producing a thermal effect. Therefore, severity of lesion varies directly with degree of pigmentation of fundus, duration of exposure with climatic condition during exposure. Symptom persistent of negative after image of sun processing later into positive scotoma and metamorphosia. Decreased vision which develops within 1 to 4 hours after solar exposure. Signs: Initially, the fundus may appear normal. After exposure, a small yellow spot with grey margin may be noted in the foveolar parafoveolar region. Typical lesion which appears later consists of central burnt out hole in pigment epithelium surrounded by aggregation of mottled pigment. Ophthalmoscopically, it appears as a bean or kidney-shaped pigmented spot with yellowish white center in foveal region. In worst cases, typical macular hole may appear. Treatment: there is no effective treatment for retinitis, so emphasis should be on preventive. Eclipse viewing should be discouraged unless there is proper use of protective eyewear glasses which absorb UV and infrared wavelengths. Prognosis guarded since some scotoma and loss of visual acuity by 1 or 2 lines mostly persists. Central serious chorioretinopathy characterized by spontaneous serious detachment of neurosensory retina in macular region with or without retinal pigment epithelium detachment. Etiopathogen risk factor: age, males more than females. Personality: type A personality individual more prone. Steroid intake is important risk. Emotional stress, hypertension, pregnancy, causing a pathogen is not known. Various theories have been possible. Presently, the most accepted theory of choroidal vascular hyperpermeability. This theory correlates the clinical findings of endocyanine green angiography finding. It proposed that sympathetic drive sympathomatics and cardiovascular after choroidal vascular permeability either directly or indirectly by affecting its autoregulation. This in turn increases the tissue hydrostatic pressure in choroidal, causing pigment epithelial defect. Leakage of fluid across this area results in development of localized serious detachment of neurosensory retina. Clinical features: patient may present with sudden painless loss of vision 6/9 to 6/24 associated with relative positive scotoma, micropsia, metamorphosia. Biomicroscopic fundus exam reveals mild elevation of macular area demarcated by circular ring reflex. Small yellowish grayish elevation may be seen due to RPE detachment. Foveal reflex is absent or distorted. Subretinal deposition may be seen. Multifocal pigment changes suggested chronicity. Clinical course: CSR is usually self-limiting but often recurrent. 3 patterns are known: vitiliform disease, egg yolk lesion at macula, fundus photograph showing ventral retinous center serious retinopathy. Acute classic CSR: fundus fluorescein angiogram showing ink blot pattern. Ink blot pattern and smokestack pattern and of hyperfluorescence in central serous retinopathy and OCT picture of CSR. Acute classic CSER is characterized by short clinical course with spontaneous resolution within 3 to 6 months with near normal visual recovery. Recurrence are known in 30 to 50% of cases. Chronic CSR, also known as diffuse retinal pigment epitheliopathy, is seen in few cases. It is characterized by chronic course lasting more than 12 months, typically affecting individual more above 50 years of age. Such cases may have permanent visual impairment due to progressive RPE atrophy and photoreceptor degeneration. Bullous CSR present is rare presentation characterized by larger, more numerous areas of serious retinal RPE detachment confused with bullous retinal detachment. Investigation: fundus fluorescent angiography, ink blot appearance. It consists of small hyperfluorescent spot which gradually increase in size. Smokestack consists of small hyperfluorescent spot which ascends vertically like a smokestack, gradually spreads laterally to take a mushroom umbrella configuration. ICG shows multiple areas of hyperfluorescence due to choroidal hyperpermeability. OCT shows neurosensory retinal detachment and accompanying small detachment of RPE. OCT is a retinal detachment. Differential diagnosis include other entities which may produce serious detachment of sensory. These include optic pit, idiopathic polypoidal choroidal vasculopathy, macular hole with serious detachment, choroidal tumors, pigment epithelial defect. Treatment: conservative, discontinuation of steroids if possible should be done at earliest. Lifestyle changes, laser photocoagulation. Long-standing cases more than 6 months. Patient having recurrent CSR with visual loss, patient having permanent loss of vision. Another eye contraindication include cases having leak near or within FAZ. Photodynamic therapy may be beneficial for those with severe disease not amenable to conventional laser therapy. Anti-VEGF can be considered if CNV develops. Fundus photography showing honeycomb appearance in cystoid macular edema. Honeycomb appearance in cystoid macular edema. Cystoid macular edema. Cystoid macular edema, it refers to collection of fluid in the outer plexiform Henle's layer, inner nuclear layer of retina, centered around the fovea. Etiology, it is causes with number of disorders. Following common causes are as follows: complication of ocular treatment such as ocular surgery, cataract extraction, Irvine gas syndrome, penetrating keratoplasty, glaucoma filtration surgery, retinal detachment surgery, ocular laser therapy, pan-retinal photocoagulation, PRP, YAG laser capsulotomy, topical ocular therapy with eye drops like epinephrine, dipivefrin, prostaglandin analogs, especially in patients who have undergone cataract surgery. Retinal vascular disorders, example diabetic retinopathy, central retinal vein occlusion, branch retinal vein occlusion, retinal telangiectasia, Coats disease, Ehlers disease, hypertensive retinopathy, intraocular inflammation, pars planitis, positive uveitis, retinitis pigmentosa, macular epiretinal membrane, vitreomacular traction syndrome, systemic disease such as leukemia, chronic renal failure, multiple myeloma. Miscellaneous causes include intraocular tumor, choroidal neovascularization, collagen vascular disease. Pathogenesis. CMA develops due to leakage of fluid following breakdown of inner blood retinal barrier and accumulating in the outer plexiform inner layer of retina with formation of cyst-like changes are depicted in OCT macular scan. Leakage from retinal capillaries and accumulating in outer plexiform inner nuclear area of retina with formation cyst-like changes. Outer retinal and inner plexiform layer, outer plexiform and inner nuclear layer of retina, formation of cysts are seen. Clinical feature: visual loss. Ophthalmoscopy reveals loss of foveal contour, retinal thickening, yellow spot at center of fovea, honeycomb appearance of macula due to multiple cystoid oval spaces. CME is best examined with fundus contact lens on slit lamp 90D plus 90D. Associated feature depend on underlying cause. Example CRVO. Visual loss. Fundus fluorescent angiography FFA. Flower petal appearance in frame 12.25A. Flower petal appearance in FFA. Fundus fluorescent angiography. Optical coherence tomography reveals loss of foveal depression, intraretinal area of decreased reflectivity with round optical clear regions and overall retinal thickening. Detection rate on OCT is similar to FFA. It can also detect associated specific pathology. Example vitreomacular traction. Complication: long-standing CME may end in lamellar macular hole. Treatment of causative photocoagulation for diabetic CSME, cessation of causative topical 2% adrenal eye drops, topical antiprostaglandin drops like diclofenac, profenac, when used pre and post prevent the occurrence of CME associated with intraocular surgery. These are also useful in the treatment of most CMEs. Topical and systemic steroid may use of established cases. Systemic carbonic anhydrase inhibitor include oral acetazolamide may be beneficial in some cases of CME. Example retinitis pigmentosa. Age-related macular degeneration. Senile macular degeneration over 50 years, 65 years. ARMD, age-related disorder. Risk factors include age, progression include hereditary, nutrition, smoking, hypertension, sunlight exposure, hyperopia, blue eyes, cataract, nuclear opacity in cataract. Non-exudative or atropic Atrophic ARMD. It is also called dry or geographic ARMD. Responsible 90% cases. It is typically caused mild to moderate gradual visual loss. Mild to moderate. Asian complaint of distorted vision, difficulty in reading due to central shadowing. Central shadowing, important condition. Signs ophthalmoscopically. Lesions of non-exudative ARMD can be described in 3 stages. Figure 2.6. Early stage, intermediate stage, advanced stage. Early, characterized by occurrence of macular dehiscence, focal hyperpigmentation, pale area of retinal pigment atrophy or P atrophy. Macular dehiscence are well defined, yellowish white, slightly elevated spots in early cases. Less than 20 small to medium sized dehiscence are seen. Intermediate stage cases show sharply circumscribed circular areas of RPE atrophy with variable loss of choriocapillaries along with drusen. One large drusen is greater than 125 micrometer or 20 medium drusens. Large drusens are soft drusens with less sharply defined edges. Advanced stage cases show enlargement of atropic areas within which larger choroidal vessels may become visible and pre-existing drusen disappear. Geographical atrophy. Exudative ARMD or wet neovascular responsible for only 10% of cases, but also comparatively rapid progressive marked loss of vision. Typical lesions are drusens with retinal pigment epithelial detachment (PED), seen as sharply circumscribed dome-shaped elevation. Choroidal neovascularization proliferating in subretinal space. Type 1 is seen as grayish green or pinkish yellow raised lesion. The CNV proliferating in subretinal space is seen as subretinal halo or pigment plaque. Hemorrhagic pigment epithelial detachment. It appears as dark elevated mount. Hemorrhagic detachment of neurosensory retina which assumes diffuse outline and a lighter red color around adjacent to PED. Risky form subretinal. Diagnosed by slit lamp biomicroscope with plus 90 or 70/80. Non-contact or mainstay lens. Fundus fluorescent FFA. Age-related macular degeneration. Non-exudative. Exudative FFA showing leak and lacy pattern in CNVM. Exudative FFA showing leakage and lacy pattern in CNVM. OCT picture of CNVM. Fundus fluorescent angiography and endocyanine green angiography help in detecting choroidal neovascularization in relation to foveal avascular zone. CNV may be classical or occult. Choroidal neovascularization CNV classic is seen as lacy hyperfluorescence with progressive leakage. Is classical. It may be subfoveal, juxtafoveal, extrafoveal in location. Occult is seen as tripled hyperfluorescence, type 1 or late leakage of undetermined source. Optical coherence tomography reveals subretinal fluid, intraretinal thickening, choroidal neovascularization, hemorrhages in exudative ARMD. Treatment of non-exudative ARMD. Currently, there is no effective treatment that stops progression of dry AMD. Measures to be tried include dietary supplements and antioxidants, age-related eye disease, that use of certain specific antioxidant minerals, vitamin E, beta carotene, vitamin C, zinc oxide, cupric oxide could be possible to prevent or delay progress of ARMD. Smoking cessation. Amsler grid used regularly allows the patient to detect new or progressive metamorphosia. Refraction with increased near add may be helpful in early cases. Low vision aid may needed in advanced cases. Treatment. ARMD treatment. Intravitreal anti-VEGF therapy, bevacizumab, ranibizumab, tegatabib. They improve vision by 30 to 40%. Photodynamic therapy is treatment of choice after anti-VEGF injection for subfoveal, juxtafoveal classic CNVM. In photodynamic therapy, verteporfin, a photosensitive or light activated dye is injected intravenously. The area of CNVM is then exposed to light from diode laser source at wavelength. that correspond to absorption peak of the dye. The light activated dye then causes disruption of cellular structures and occlusion of CNVM, minimum damage to adjacent RPE, photoreceptors and capillaries. Transperipheral thermotherapy TTT with a diode laser may be considered for subfoveal occult CNVM. PDT is definitely better than TTT but is expensive. YAG laser, photocoagulation, surgical treatment. Submacular surgery to remove CNVM, macular destruction surgery are being evaluated. Macular hole goes to partial thickness of full thickness or full thickness hole in neurosensory retina in foveal region. Cause senile or idiopathic, more common in females. Traumatic, other causes, cystoid macular edema, etc. Membrane traction. Pathogenesis. Senile macular holes are caused by tractional forces associated with the early PVD. Symptoms: decreased vision, metamorphosia or distorted vision, central scotoma. Signs: fundus appearance in 70 or 90D slit lamp examination. Stage 1, impending hole. It is characterized by absent foveal reflex, yellow spot. Stage 1A or yellow ring. Stage 1B in the foveal region. OCT examination reveals pseudocyst with vitreous detachment in stage 1A and progression of pseudocyst with breakage in outer foveal layer in stage 1B. Fundus yellow spot. A small full thickness hole is seen either in the center of ring or at margin of the ring eccentric. OCT examination full thickness hole less than 400 micrometer. Stage 3, a full thickness hole is seen as rounded reddish spot surrounded by grey halo, cuff of subretinal fluid but no PVD. OCT examination full thickness macular hole more than 400 micrometer with partial vitreomacular adhesion traction. Stage 4, full thickness hole with SR of cuff and complete PVD, that is posterior vitreous detachment seen as Weiss ring. OCT examination confirm large full thickness hole with posterior vitreous detachment from discant macula. Management: DD, macular pucker, solar retinopathy, interretinal cyst, vitreomacular traction syndrome. Investigation: fundus fluorescent angiography, optical coherence tomography. Fundus fluorography reveals foveal hyperfluorescence without leak in late phase in patients stage 2 or stage 4. OCT for differentiating true holes from lamellar holes and cysts. Staging of macular hole. Planning the surgery. Determining the degree of traction from epiretinal membrane. Treatment: stage 1, treatment is not recommended as spontaneous hole closure can occur, but close follow-up should be done. Stage 2 to 4, recent onset where reduced visual acuity, should be treated with pars plana vitrectomy with posterior hyaloid removal, internal limiting membrane peeling and gas or silicone oil tamponade with strict post-operative face down position for 7 to 14 days. Prognosis: anatomical closure reported. Complication: occurrence of progression may done. Retinal detachment. Retinal detachment is separation of neurosensory retina proper from pigmental epithelium. These two layers are loosely attached to each other. The potential space between them. Classification: they are classified. We will see the diagram. Macular hole stages 1, 2, 3, 4. OCT pictures: stage 1, stage 2, stage 3 and stage 4. The classification of retinal detachment is regnomatous, regnomatogenous, primary retinal detachment, tractional retinal detachment, exudative retinal detachment. Etiology: regnomatous, primary retinal detachment associated with retinal break, whole artery through which subretinal fluid seeps, separates the sensory retina from pigmentary epithelium. Etiology: predisposing factors include age, sex, myopia, aphakia, pseudophakia. More common aphakia, retinal degeneration, lattice, snail track, white with pressure, focal pigment clumps, trauma, senile posterior vitreous detachment, pathogenesis, RRD. It's summarized in figure 12.28. Flowchart depicting pathogens of retinomatous retinal detachment. Senile acute posterior vitreous detachment. Acute posterior vitreous detachment. Predisposing retinal degeneration. Aphakia. Endodonesis, which causes retinal breakage. Trauma also causes retinal breakage. The degeneration fluid vitreous seeps through retinal break and collects as subretinal fluid between the sensory retina and pigment epithelium. Then retinal detachment occurs as fluid accumulates. This is the pathogenesis. Liquid vitreous may be seeped through separating sensory retina and pigment epithelium. As subretinal fluid accumulates, it tends to gravitate downwards. Then there occurs retinal detachment. The final shape and position of retinal detachment determined by location of retinal break. Location gives link of rule, given by link of rule, and the anatomical limits of optic disc and ora serrata. The degenerate fluid vitreous seeps through retinal break and collects as subretinal fluid. Clinical feature: dark spots, photopsia. Symptoms of detached retina: localized relative loss in field of vision is noticed by patient in early stage, which progresses to total loss when peripheral detachment proceeds gradually towards the macular area. Sudden appearance of dark cloud or veil in front of eye is complained by patients when detachment extends posterior to equator. Sudden appearance of dark cloud or veil. Sudden painless loss of vision occurs when detachment large. Signs there are elicited. These are elicited on following examination. External examination: eye is normal. Intraocular pressure is usually slightly lower or normal. Marcus gun pupil related to afferent pupillary defect RAPD is present in eyes with extensive RD. Plain mirror examination or distant direct ophthalmoscopy reveals an altered red reflex in pupillary area, that is grayish reflex in quadrant or detachment retina. Ophthalmoscopy should be carried out both direct and indirect techniques. Retinal detachment is best examined by indirect ophthalmoscopy using scleral intention to enhance visualization of peripheral retina anterior to equator. Freshly detached retina gives grey reflex instead of normal pink reflex and is raised anteriorly. It is thrown into folds which oscillates with movements of eye. These may be small or may assume the shape of balloons. In large balloons, bulbous retinal detachment. In total detachment, retina becomes funnel shaped and being attached only at the disc and ora serrata. Retinal vessels appear as dark tortuous cords oscillating with movements of detached retina. Retinal breaks associated with regmatogenous detachments are located with difficulty. These look reddish in color, vary in shape. These may be round, horseshoe shaped, slit like, or in the form of large anterior dialysis. Horseshoe tear, round retinal hole, anterior dialysis. Retinal breaks are most frequent found in peripheral, common in upper temporal quadrant. Associated with retinal degeneration, pigmentation hemorrhages may be discovered. Vitreous pigments may be seen in anterior vitreous with posterior vitreous detachment. Old retinal detachment is characterized by retinal thinning due to atrophy, formation of subretinal demarcation line, high watermarks due to proliferation of RPE cells, of junction of flat detachment, formation of secondary intraretinal cysts. Visual field charting reveals scotomas corresponding to area of detached retina, which are related to begin with but become obsolete in long-standing cases. ERG is abnormal or absent. Ultrasonography confirms the diagnosis. It is of particular value in patients with hazy media, especially in presence of dense cataracts. Complications usually long-standing cases include proliferative vitreoretinopathy, complicated cataract, uveitis, thysis, treatment. Sealing of retinal plaques. All the retinal plaques should be detected, accurately localized and sealed by producing aseptic chorioretinitis. Cryocoagulation, photocoagulation, diathermy is most frequently utilized. Drainage of SRF. It usually in immediate opposition between sensory retina and RP. SRF drainage is done very carefully by inserting a fine needle through sclera and choroid into subretinal space and allowing SRF, that is vitreous, to drain away. Maintenance of choroidal apposition is required for at least a couple of weeks. This can be accomplished by either of following procedures depending upon the clinical condition of eye. Scleral buckling. Inward intention of sclera to provide external tamponade is still widely used to achieve the above mentioned goal successfully in simple case of primary RD. Scleral buckling is achieved by inserting an expand with help of mattress type switches applied in the sclera. Cryocollation of retinal whole area under direct vision with indirect ophthalmoscopy. Cryo is under low temperatures. Tip temperature is -70°, freezing the tissue on contact. Pressure under direct vision. It causes the sealing effect at Voros areata. Then diagram depicting scleral buckling and subretinal fluid drainage. Scleral buckling and subretinal fluid drainage. Pneumatic Retinopaxy is a simple outpatient procedure which can be done. It can be used to fix a fresh superior RD with 1 or 2 small holes extending over less than 2 o'clock hour area in the upper 2/3 of peripheral retina. In this technique, after sealing this breaks the cryopaxy and expanding gas bubble sulfur hexafluoride injected in the vitreous. Then proper positioning of the patient is done so that the break is uppermost. Pars plana vitrectomy, endoless photocoagulation, internal tamponade may also be done. All complicated primary RDs, all tractional RDs. Presently, even in uncomplicated primary RD also carried out. Main steps of procedure are pars plana 3-port vitrectomy is done to remove all membranes and vitreous to clean edges of retinal breaks. Internal drainage of SRF through existing retinal breakups using fine needle. Flattening of retina is done by injecting silicone oil or perfluorocarbon liquid. Endolysis then applied around the area of posterior retinectomy. Retinal tears holes to create chorioretinal adhesion. To tamponade the retina internally, either silicone oil is left inside or is exchanged with some long-acting gas. Silicone oil gases commonly used to tamponade the retina are sulfur hexafluoride, perfluoropropane. Prophylaxis of primary retinal can be prevented by timely application of laser photocoagulation, cryotherapy in areas of retinal breaks, or predisposing lesions like lattice degeneration, etc. Exudative or solid retinal detachment. It is serous, occurs due to retina being pushed away by a neoplasm or accumulation of fluid beneath the retina following inflammatory vascular lesions. Etiology: common systemic disease, renal hypertension, pregnancy, blood dyscrasis, polyarteritis nodosa. Ocular disease, congenital abnormalities such as non-ophthalmos, optic pit, choroidal globoma, family exudative vitreoretinopathy, inflammation such as Khurana disease, sympathetic ophthalmia, posterior scleritis, vascular disease, neoplasm, melanoma of choroid, retinoblastoma, hemangioma, metastatic tumors, sudden hypertony, uveal effusion syndrome, choroidal neovascularization. Clinical feature: absence of photopsia, holes, tears, folded, exudative retinal detachment, smooth and convex. Exudative retinal detachment patient with malignant melanoma of choroid, smooth and convex. Exudative retinal detachment. Pattern of retinal vision may be disturbed occasionally due to presence of neovascularization on the tumor summit. Shifting fluid characterized by changing position of detached area with gravity is hallmark of exudative retinal detachment. On transillumination test, a simple detachment appears transparent while solid detachment opaque. In investigation, ocular and systemic examination should be carried out thoroughly. B-scan ultrasonography. FFA may show source of fluid. CT scan. Treatment cause is required in most of the cases. Enucleation is required in presence of intraocular tumors. Tractional retinal detachment occurs due to retina being mechanically pulled away from its bed by contraction of fiber tissue in vitreous. Post-traumatic retraction of scar tissue, especially following penetrating injury. Proliferative diabetic retinopathy, post-hemorrhagic retinitis proliferans, retinopathy of prematurity, plastic cyclitis, recurrent retinopathy, proliferative retinopathy in Eales disease, vitreomacular traction syndrome, incontinentia pigmentary, retinal dysplasia, toxocaritis, etc. Clinical feature: presence of vitreoretinal bands with lesions of cosset disease. Retinal breaks are usually absent with configuration of detached area is concave. Highest elevation of retina occurs at sites of vitreoretinal traction. Retinal mobility severely reduced and shifting fluid is absent. Treatment: surgery is difficult and requires sparse planar vitrectomy to cut the vitreoretinal traction bands and internal tamponade with either long-acting or gas or silicon. Prognosis in each case is usually not so good. Tractional retinal treatment patient with advanced diabetic retinopathy. Tumors of retina: primary tumors, neoplastic tumor, mesodermal angioma, phacomatous, secondary tumor, direct extension, metastatic carcinoma, metastatic sarcoma, metastatic malignant melanoma, retinoblastoma, RB. Demographic: it's most common intraocular tumor of childhood. Age: retinoblastoma is confined to infancy, very young children, usually seen between 1 to 2 years. No predisposition. Race: rare in Negroes and whites. Bilateral: 25 to 30% cases there is bilateral involvement. Genetics: RB gene as identified 14 band on long chromosome 13q14 is a cancer suppressor anti-oncogenic. Deletion of inactivation of both the normal alleles of this protective gene by 2 mutation. Knudsen 2-hit hypothesis result in occurrence of retinoblastoma. Some facts about occurrence of retinoblastoma include of all cases only 10% of familial, sporadic cases about 60% of all cases by somatic mutation, 1/3 by germline mutation. Thus retinoblastoma either occurs heritable and non-heritable. Heritable: in such cases this occurs in one of the 2 alleles of retinoblastoma gene on germ cells before fertilization. This occurs in 40% of cases either from affected parent or sporadically in one of the gametes. Sporadically or affected parent. This means mutation will occur in somatic cells predisposing to development even non-ocular tumors such as osteosarcoma. Second hit occurs late in post-zygote phase, affects second allele of one or more retinal cells, resulting in multifocal and usually bilateral tumor formation. About 50% of irritable cases are unilateral. Some irritable cases have trilateral retinoblastoma. Irritable case can transmit the disease by autosomal dominant way to 50% of offspring. Non-irritable or somatic, about 60% retinoblastoma occurs sporadically by both hits, 2 hits hypothesis. Pathology: origin: retinoblastoma arises as malignant proliferation of immature retinal neural cells, which are small round cells with large nuclei. It is tumor of group called small round blue cell tumor. Histopathology: tumor chiefly consists of small round cells, large nuclei. These cells may resembling cells of nuclear layer of retina. These present high undifferentiated or well differentiated tumor. Microscopic features include well differentiated tumor include Flexner Wintersteiner rosettes, highly specific of retinoblastoma. Homer Wright rosettes, pseudo rosettes, florets formation, etc. Clinical feature given in table. Intraocular, these can be described in stage wise below. Intraocular stage of retinoblastoma, it can be divided into 2 groups. Quiescent presentation include leukocoria or yellowish white pupillary reflex. Amaurotic cat eye appearance. Leukocoria, right eye in a patient with retinoblastoma. Cat eye appearance, amaurotic. Commonest presenting feature, common. Leukocoria, strabismus, painful red eye, poor vision, asymptomatic, orbital celerity, unilateral metastasis, hypema. Squint, usually convergent, is the second commonest mode of presentation. Squint. Defective vision, nystagmus, bilateral cases. Ophthalmoscopic features of tumor. In early stage, before appearance of leukocoria, fundus examined after full maintenance performed in children. Endophytic retinoblastoma, it grows inwards from retina into vitreous cavity. On ophthalmoscopic examination, tumor looks like well sectional polypi in mass, white or pink color, fine blood vessels, and sometimes hemorrhage may be present on its surface. In the presence of calcification, it gives typical cottage cheese appearance. Exophytic retinoblastoma, it grows outwards and separates the retina from choroid. On fundus examination, it gives appearance of exudate retinal detachment. Diffuse infiltrating tumor shows just a placoid thickness of retina and not a mass. Such cases are usually diagnosed late. Painful red eye presentation: when retinoblastoma is left untreated during quiescent stage, some patient may present with severe pain, redness, watering. These symptoms may occur due to acute secondary glaucoma or apparent intraocular inflammation or apical cell disease. These are differential diagnosis. Diagrammatic depiction A and D. Fundus photography B and E. CT MRI C and F of endophytic and exophytic retinoblastoma. Endophytic, exophytic, RB. acute secondary glaucoma, may occur either due to tumor pushing the lens iris diaphragm forward or tumor cells clogging the trabecular muscle. Eye is enlarged. Ophthalmos. Apparent intraocular inflammation, occasionally picture simulating severe acute uveitis, usually associated with pseudohypopia and hypema. Orbital cellulitis like presentation occurs with necrotic tumors. Classification of retinoblastoma. Selworth. International classification. Group A includes small tumor less than 3 mm. Group B greater than 3 mm from fovea, greater than 1.5 mm, less than 1.5 from optic disc. Moderate risk less than or equal to 3 mm subretinal. Group D high risk retinoblastoma with diffuse seeds greater than 3 mm. Very high risk include extensive retinoblastoma. Any of them of the tumor fungating retinoblastoma involving the orbit. Stage of extraocular extension due to progressive enlargement of tumor. Globe burst through sclera, usually near the limbus, near the optic disc. It is followed by rapid fungation involvement of extraocular tissues. Stage of distant metastasis. Lymphatic spread first occurs. Direct extension by continuity to optic nerve and brain is common. DD various pseudoglioma, cyclitis, choroiditis, coloboma choroid, hyperplastic vitreous, endophytic retinoblastoma, RB, tuberous sclerosis, neurofibromatosis, astrocytoma, Coats disease, exophytic retinoblastoma. Diagnosis examination under anesthesia. Performed in non-clinically suspected cases. Brain X-ray. Lactic dehydrogenase level is raised in aqueous humor. Ultrasonography, CT, MRI. Extension of optic nerve, orbit and CNS. Treatment. Conservative treatment. Chemotherapy. Consolidation. Chemotherapy. Standard dose CVE regime. ABC patient. That's 3 weeks 6. Carboplatin, vincristine, etoposide. Anti-tumor drugs. High dose CVE. Vincristine, D and D patients. Focal therapy, cryotherapy, laser thermotherapy, plaque radiotherapy, external beam radiotherapy. Enucleation. Tumor involves more than half of the retina. Optic nerve is involved. Glaucoma is present and anti-chemb is involved. If optic nerve shows invasion, post-operative treatment should be include external beam radiotherapy, chemotherapy. Palliative therapy. Retinoblastoma with orbital extension, retinoblastoma with intracranial extension, retinoblastoma with distant metastasis. If untreated, prognosis is almost always bad. As spontaneous regression. Immunological phenomena. If eyeball is inoculated before optic nerve involvement, undifferent tumor cells and massive choroidal invasion. Enucleation. Indications. Absolute indication are retinoblastoma and malignant melanoma. Relative indication for eye donation from cadaver is presently most common. Surgical technique. Separation of conjunctiva and Tina's capsule. Surgical technique. Enucleation operation. Separation of conjunctiva and Tina's capsule. Separation of extraocular muscle separation. Cutting of optic nerve and removal of eyeball. Insertion of orbital implant. Closure of conjunctiva. Fitting of artificial prosthetic eye. Phacomatous. Photographs of patient without artificial eye, with artificial eye. Which are characterized by development of neoplasia, eye, skin. Angiomatosis, retinae. One Hippo Linda syndrome. Angiomatosis, clinical feature of clinical cause of angiomatosis retinae comprises of vascular dilation, toxicity, formation of aneurysm. Tuberous sclerosis, bone meal disease. It is characterized by classical triad of adenoma, sebaceum, mental retardation, epilepsy, etc. Neurofibromatosis, von Recklinghausen, encephalofacial angiomatosis, characterized by angiomatosis in form of port vein stain.